As you've heard, I'm a gastroenterologist, and I have been involved with caring for a lot of patients with Parkinson's disease. And also have been doing a fair amount of research and understanding. I've been doing a lot of research to help us understand the disease from my perspective, which is obviously the gut. I'm not a neurologist. I'm working with a few neurologists in my area. And I had the opportunity to do a lot of research in the theme of Parkinson's disease in the gut, and I'm going to share with you some of my insights so you can process them and you can consider evaluation that would pertain to gut function or malfunction in Parkinson's disease. So I'm going to start with a clinical case. This is a case of a 66-year-old man who has Parkinson's disease, who presented to the emergency department with difficulty breathing and severe constipation. And going to the emergency room these days, you end up having a CAT scan, which they did. They found this severely distended colon with stagnation of feces all in it. There was no evidence of any major perforation of the bowel. What you see here is the colon has been dilated from here to here, which is about 5 to 10-fold dilation, and it's full or packed with fecal contents, and then it twists around in this area here. The patient was very distended, couldn't even breathe because of that degree of distension. They had to use what we call manual disimpaction, which is not particularly pleasant, but nevertheless it's important in these circumstances. And they did multiple enemas to try to get rid of all the stool out of the bowel. After that, they used something that we call osmotic laxatives. A common of these is so-called Miralax. And they used another drug called linaclotide or Linzess. And they did another thing which is actually quite useful in the circumstances, something that's called programmed defecation, which an assistant or the patient themselves that tries to manipulate the distal part of the bowel to basically manual disimpact the bowel to give that person relief. So this is basically an extreme degree of malfunction, but it happens a lot. And the common theme behind this is the overuse of fiber. Don't be shocked, but I'm sure you have been told by your gastroenterologist, by your primary care doctors, oh, use fiber, it's going to be okay. Typically, in a Parkinson's situation, is not a good idea. And it's best before you do that to try to have an evaluation, as I will talk about in a minute. Briefly, you all know about Parkinson's disease. It's a progressive neurodegenerative disease, affects about 1 million people in North America. The symptoms involve tremor, slow movements, rigidity, but there are a lot of gastrointestinal symptoms, particularly constipation, that impair the quality of life of individuals suffering from the disease. And indeed, people who have asked the question, what bothers you the most? It's not the neurologic symptoms as much as the gut symptoms, which I was shocked when I found that out. It also is associated with neuropsychiatric issues, and particularly non-motor manifestations, such as you heard, cognitive changes, dementia, etc. It is due to the loss of dopaminergic neurons and formation of something that's called alpha-synuclein that traps itself in the so-called Lewy bodies and Lewy neurites in the remaining neurons of the area of the brain that accumulates the substances, and that creates the problem with the symptoms, neurologic symptoms. So one major development that still has not been fully pursued, and I'm sure you want to hear about it, is the gut-brain link in Parkinson's disease. The experiments that have been done so far have been done in animals, not humans. And what they have done is that they have actually tried to see if there's any connection between the gut shown here and the brain showing up here. And they actually injected either albumin, which is a benign molecule, or an extract from brain of patients who had died of Parkinson's disease, or fibrils of alpha-synuclein. And when you inject that here in the gut, and you follow the animal at about 2 to 3 to 6 days, you can actually appreciate upon autopsy of the animal that these molecules have gone up to the brain. So there is a direct connection, almost like the freeway, to go up to the brain. So that is pulled up from the nerves that connect the gut to the brain, and it's pulled up to here, and then it's deposited here. So these special lysates or fibrils end up going into the brain and they stay there. And that accumulation progressively creates this slow neurodegenerative process of Parkinson's disease. This is very difficult to reproduce in humans, and obviously that will require a significant amount of research in which it will be done, the same experiment will be done and proven, but the problem is that it's very hard to do the analysis of the brain, obviously because it needs to be removed. Nevertheless, I wanted to give you briefly a synopsis of what can happen to the gut in patients with Parkinson's disease. We're doing a study that actually looks at the natural history of the disease. In other words, we enroll patients who start out at year 1 and then they're followed for years 2, 3, 4, 5, using a variety of tools, both questionnaires as well as simple non-invasive tools in assessing the disease in the gut. And we're hoping that we'll be able to pick up signals from the gut that will be rhyming along with what's happening in the brain of patients with Parkinson's disease, as well as the neurodegeneration that happens in the rest of their body. Unless such natural history studies are done, we're not going to have a good understanding of the disease and its relationship to the gut dysfunction. Obviously, the gut is easy to get access to as opposed to the brain, but we're hoping to create a situation in which we're going to follow the parallel paths between the gut dysfunction and the brain dysfunction in such patients. But it has to be done prospectively, and it has to be compared with control individuals who do not have the disease, as well as with people who have a strong history of family members with the disease and they consider it to be a high risk for this condition. Nevertheless, the symptoms that we do encounter from my perspective as a gastroenterologist are difficulty swallowing, nausea and early fullness after a meal, a bloating sensation, constipation, and fecal incontinence. Not necessarily in this order. I just thought that they start from the top and go to the bottom. We have a variety of tools to assess for all these conditions, and I will spend some time reviewing for you. So there's a lot of work that can be done to understand the condition of the gut in the context of Parkinson's disease. What is not happening today, despite our sophisticated community here, particularly in Northern California, is that my average colleague, gastroenterologist, does not have the tools and does not have the knowledge necessarily to deal with this. And it's frequently kind of put aside without really significant thought process. So it does require a sophisticated gastroenterologist like myself, for example, but it does require special training after the training in gastroenterology to understand the nuances of the condition and the tools that are required to assess it. And there is a new specialty called gastroenterology, in which physicians go through internal medicine training, that's the primary care physicians, then they go through 3 years of gastroenterology training, and then an additional year to understand neurogastroenterology, and to understand the tools of what we can do to not only understand the disease, but to help the individual patient with the disease vis-a-vis their gastrointestinal symptoms. The tools that we have are questionnaires, which require a very significant and sophisticated approach that the questionnaires will actually yield the information that we need. High-resolution manometry, which is a tool that in a matter of 10 to 15 minutes can assess different parts of the body, specifically the esophagus and the bowel. Something that we call wireless capsule motility, and wireless capsule endoscopy, and then Black Jewel's breath testing, which allows us to find out if there's any bacterial infection in the gut. And there's also high-resolution anorectal manometry, which allows to assess the functionality of the gut in these individuals. For all these tools, you need special training and availability of the tools to really have it and use them in an everyday practice. And unfortunately, that availability is kind of limited, even in our communities here in the Bay Area. I'll give you an example. An esophageal motility test looks something like that. This is the normal study that gives you a map between blue, green, and red. This is an abnormal but very high spastic condition of the esophagus that impairs swallowing. And there's, as you can see here, the lack of such motility, in which every time the patient swallows, nothing is happening as you go down. So to interpret these tracings, you need to have a special knowledge, but also to have the equipment for that is very expensive. So the average gastroenterologist today does not have that equipment unless there is a flow of patients to sustain this operation. We're talking about hundreds of thousands of dollars, all of the initial capital investment. Then there are tools that generally are more available even in community hospitals, which are actually done by physical therapists, not gastroenterologists, and these are the tools that assess how the pharynx and the proximal part of the esophagus are working and how they are coordinating. And that can be done, again, in sophisticated places, but generally there is a little bit of a better availability because they're easier tools to use by physical therapists and so-called speech therapists. The tool that I mentioned earlier, the wireless motility capsule, is a capsule that patients swallow. This looks quite big, but it's like a big vitamin pill. And then it contains electronics, and as this is swallowed and goes down, you can measure the transit time as it goes down the path of the stomach, the small intestine, and the colon. And then the patient carries a recorder shown here that takes the information out of this capsule, and then the patient 5 days later returns that recorder to the physician's office, and then there's an analysis that you see here on the computer that, depending on the pattern of movement through the gut, we can actually deduce how quickly or not, or how effectively or not, this capsule went through the gut and was eliminated by the body. But just to have an idea, this technology is available in the Northern California area in about 3 or 4 places. And each test, each one of these capsules costs about $600. So it's not something that is readily available, and sometimes insurers don't cover it. So there are all kinds of obstacles that pertain to our suffering health care system. I just wanted to show you an example of these tracings as they become available. This tracing records the pH of where it is, the capsule is. It records the pressures on the bottom, and it records basically the coordination between the structures as you go down over the course of 5 days. So it gives a significant amount of information as to how well or not well the gut responds to normal digestive process. An easy test, again, usually easily available, is something that's called a lactulose breath test, and that allows us to measure the presence of abnormal amounts of bacteria in the gut. Using this test, which takes about an hour to do, it's very non-invasive, we can find out if the particular subject has an abnormal amount of bacteria in their intestine. You will be surprised, I was surprised, that about 30% plus of patients with Parkinson's disease, without even knowing about it, they have this infection. And when we treat the infection over the course of 2 weeks, their symptoms of Parkinson's, not the gut symptoms, but the Parkinson's symptoms, improve significantly. And I actually was surprised to see that. My neurology colleagues were surprised to see that. And the patients were actually pleasantly surprised to see that they went through a period in which they actually felt significantly better. Another tool which is also important, a very easy test to do, is to study how the process of defecation takes place, how we try to move our bowels in the context of this disease. And we can do all kinds of assessments with this tool, which takes literally 15 minutes to do for the patient. It takes about another half an hour plus for the physician to interpret those complicated images that you see here. But nevertheless, this is probably 90+% abnormal in patients with Parkinson's disease, and it leads to severe constipation and as we call it, defecatory dysfunction, such as the patient that I showed you early on. So this is an important and essential tool to make us understand what's going on and then allow us to apply specific therapies that will be more effective than others applied in an empirical basis. So let's start with just briefly some overview things of what we can do. If you look at the patient who has difficulty swallowing, otherwise called dysphagia, this dysphagia is categorized in two significant categories. One is the oropharyngeal dysphagia, in which the patient cannot initiate the swallow. Things are trapped in the back of the throat, which is very significant and very common in patients with Parkinson's disease. That is assessed using the video fluorography that typically the speech therapists do, and it's generally available. And then there is the esophageal dysphagia, which is analyzed by the tracings that I showed you earlier, of which you have these curves of blue, green, and red. So there are two categories: the esophagus, which is down here, which is frequently impaired in its function, the muscle is not working very well, and the muscles of the back of the throat also do not work in the oropharyngeal type. The treatments are different, and they both need to be assessed at the same time, even if the patient complains of difficulty swallowing. So we need to really assess both of these conditions. Then another frequent symptom in patients with Parkinson's disease, at least from my perspective, is the sensation of bloating and abdominal distension that happens a lot. It could be because of something that we call gastroparesis, which means that the stomach is not working properly and does not empty its contents after a meal. And that can be assessed by that capsule that I showed you earlier. Small bowel bacterial overgrowth, or SIBO, which is an infection by bacteria that stagnate there, and can be assessed again by the lactulose breath test that I showed you earlier, and also by the wireless motility capsule. And then there's the constipation that again can be assessed by the wireless motility capsule or the high resolution anal manometer. To return to this issue of the SIBO, not only causes the symptoms of bloating and distension, but also it impairs the absorption of the pills that patients with Parkinson's disease have to take every day or multiple times a day. The gastroparesis also impairs the delivery of these pills down to the gut where the absorption takes place. So you have a lot of discoordination between taking the pill and the time the pill makes it into the circulation to have the effect on the functionality of the nervous and neuromuscular system. So all of these can play a significant role in the adjustment of medicines that people with Parkinson's disease need to make as they live their life on a daily basis. The constipation is not necessarily involved in this process because all the colon does is basically makes the stool harder, so we don't really have diarrhea or accidents. So it's not necessarily involved in the absorption of pills, but may make the patient uncomfortable. For a minute, I would like to focus on the definition of chronic constipation, because I do see a lot of patients who complain to me about constipation, but they're not truly constipated. So it's important to know what is constipation. Constipation is defined as stool frequency either of less than 3 times a week, or too infrequent, too little, or too hard stools. It's also lack of urgency to defecate or to move your bowels, and that's something that happens in patients with Parkinson's disease. They don't really have the feeling of a need to go to the bathroom, and then things stagnate, as I showed you that initial case. Also, there's another thing that happens in patients with Parkinson's disease, and something that's called defecatory straining. They go to the bathroom, they have the urge to go, and they cannot really eliminate the stool. And that leads to something that's basically requiring a disimpaction and manipulations of using the finger, etc., etc., etc. So that's a different sensation than constipation, which is the lack of the need to go to the bathroom or the urge to use the bathroom. And it's more of the need to struggle during evacuation. And sometimes the patient has to use digital maneuvers, either the finger in the rectum or the finger in the vagina, to try to facilitate this emptying, which is obviously not pleasant. When the patient has what we call constipation, there are some possibilities that do not relate to Parkinson's disease, but somehow relate to something else. So there's a lot of causes of secondary constipation that I show you here. Drug-induced constipation is an issue, particularly in the Parkinson's population. There's a neurologic possibilities, metabolic such as diabetes or hypothyroidism, and there's also mechanical obstruction. So absolutely, one needs to have a formal assessment of the structure of the bowel to make sure that they don't have, let's say, cancer of the bowel, because that is something that needs to be excluded. And then we end up having something that's called functional constipation that happens to many people for a variety of reasons and can be managed with a variety of drugs and maneuvers. But when we have a patient with constipation, we can actually measure the magnitude of a constipation by using the tools that I showed you earlier, which is the wireless motility capsule shown here, the measurement of the defecation by using the probe that I showed you earlier, and that shows us how well or not well the muscles of the bowel and the anal sphincter coordinate itself. Normally, when we try to have a bowel evacuation, there's an anal canal sphincter that holds things in, and that sphincter does not relax to allow the passage of the stool through the push of the bowel. So this is called defecatory dyssynergia, or incoordination, if you will, of the muscle activity at the bottom part of our body, and that happens a lot in patients with Parkinson's disease, as I will show you in a few minutes. And there is something that happens, as we call it, overlap, in which both these systems are not working very well. And that happens in a significant number of patients with Parkinson's disease. Finally, the fecal incontinence issue is a significant problem in some patients, which means that they lose control of the bowels. And they prefer actually to have constipation than having accidents. They cannot go to the mall, they cannot go visit family members, they cannot go out to a restaurant. And the way that we try to treat this condition counteracts the issue of the constipation. So it's a very, very difficult and tight balance that we have to reach in a particular patient, because some of these patients may have both issues, and we need to really be particularly attentive so they can have the quality of life that they need. So now that I've given you this perspective, I will start from the top and I will go to the bottom with different abnormalities that you may encounter in patients with Parkinson's disease. And I will start with the esophagus, which is the swallowing pipe, and it's considered to be a simple organ, but it is not. And that's something that is affected by patients with Parkinson's disease. And I will give you a couple of examples. The first example on this side is you have a problem that is an infection, a fungal infection of the esophagus. When that happens, the patients tend to have pain during swallowing. And that is very easily treatable by antifungal drugs. So you may have a particular patient who had pneumonia, he was given some antibiotics, they treat themselves with antibiotics to relieve the pneumonia, and then they result to a fungal infection of the esophagus because the function of the esophagus in patients with Parkinson's disease is impaired and it does not let things to go down. So you have this candida infection as one scenario. A second scenario is that they may not be able to empty the food that they swallow. And what you see here is a food particle, a piece of chicken, for example, that may be there for a few days and they don't really know that it exists there. They have difficulty swallowing, and we have to go in there with an endoscope and remove this piece of chicken. And sometimes, actually, it happens in the middle of the night, which is not good for me, not good for the patient. And it's actually dangerous, because if it's not me or somebody who is a little bit inexperienced, they may get into trouble. And it may be quite uncomfortable for the patient and their caretakers in the middle of the night. And there is another situation that happens a lot, as you will see in a minute. That's of spastic esophagus, which is the muscle of the esophagus is very, very spastic and tight, and they don't really process the food through the esophagus into the stomach. To give you a little flavor of what we did in our original studies, now we're following the natural history study that I mentioned earlier. When we studied 95 patients with Parkinson's disease, we studied about 33 patients with symptoms who had a high-resolution manometry, and we found 31 out of the 33 had abnormal esophageal manometry, which means that if they had been studied properly, as these people did, they would have received treatment that would have been relieving of the problem of the esophagus and feeling better and the quality of life improved. So out of the 62 patients who were excluded because they did not have studies done, 28 of these patients with symptoms, 6 of them had a gastroesophageal reflux, 8 of them had oropharyngeal dysphagia, and 14 were unwilling to undergo the testing, and 34 had absolutely no symptoms. So if you don't study these people, they will not know, and you will not know, how you can help them. So these tests have value in terms of helping us understand the condition, helping us identify the people with the underlying condition, and then having, on the basis of your results, the ability to correct the problem. So if you look at the symptom prevalence in terms of the different symptoms that they have, the variety of people and a significant percentage have difficulty swallowing. The next one is weight loss, which, as you know, is very common in Parkinson's disease. And you have a variety of other symptoms, such as heartburn, reflux of fluid up into the chest of the esophagus, chest pain, and difficulty or painful swallowing. So, as you can appreciate here, 60%, anywhere 40 to 60% have the highest prevalence of these symptoms, and you go down to a variety of other possibilities. So when we take a history, we spend time identifying all of these things and making sure that we have covered all bases, if you will. In terms of the severity, the highest severity in patients with Parkinson's disease is difficulty swallowing and weight loss, while other symptoms have less severity, as you can appreciate here. If you study patients with Parkinson's disease, and in this case we studied 33 patients, you find a variety of issues here, such as something that we call esophagogastric junction obstruction. You find spasticity, as I showed you an example. You find ineffective motility, that means the muscle is very weak to push things out. Fragmented contractility, that does not really coordinate itself appropriately. And finally, a very small percentage were normal. So as you can appreciate, in the Parkinson's population, in this context, there were 33 patients that were studied. Very few of them had absolutely nothing. It was entirely normal. So again, to emphasize the point that you have to do the study so you can understand the condition better for the particular patient, and also to consider the possibility that this disease, since it's progressing, you may have to do that, let's say, a year later, 2 years later, 3 years later, because the picture may change. So these are important pieces of information I would like to share with you. I'm going to move down to the stomach and the small intestine, and I will show you an example. This is a CAT scan that is done, and the CAT scan in this particular case showed that there was significant amount of stagnation in the stomach at the time of the CAT scan that was done, and there was also stagnation of contrast and stool in the colon. So these two conditions cause fullness, early satiety, or you sit at the table and you have a little bit and then you feel full, and that leads to weight loss because of bloating or feeling of fullness. So something needs to be done for this particular condition of gastroparesis. And as I mentioned earlier, the processing, the digestion, if you will, of the pills that you're supposed to take several times a day is also compromised. So when we studied 95 patients with Parkinson's disease by formal study, which we actually were able to study 65 out of the original cohort of 95, we found that the gastric emptying time was abnormal, the small bowel transit time was abnormal, and the lactulose breath test, which again suggests that the bacteria infection was abnormal in many of these patients. The severity of these symptoms is quite interesting. If you look at the mean symptom score, you have basically the bloating sensation is the leading one, and a variety of other symptoms such as pain, feeling of fullness and regurgitation in the chest, nausea, vomiting, belching, and obviously weight loss. But the most important symptom was that of bloating. And when the patient comes in with bloating, you have to really consider all the scenarios I mentioned earlier, including the small bowel bacterial overgrowth. If one looks at the prevalence of abnormalities in Parkinson's disease, the gastric emptying time was abnormal in 35%. The small bowel transit time was abnormal in 20%. And the lactose breath test was abnormal in a third of these patients. So all these possibilities cannot be recognized on the basis of me looking at the patient and examining the patient by touching the stomach. All of these have to be explored with proper testing. So based on that testing, you need to take action. And there is also a significant overlap between, let's say, symptoms that originate from the stomach, symptoms that originate from the small bowel, and symptoms that originate from the colon. So all of these aspects have to be covered and addressed individually. The magnitude of these abnormalities can be quite dramatic. So what you see here, the normal values are down here. Oops. The normal values are down here. And you can appreciate that a significant portion of people with Parkinson's disease have abnormal stomach emptying time and also abnormal small bowel transit time. So, and these are not necessarily recognizable unless the tools are used. If you look at one test, which is the lactose breath test that looks at the bacterial infection by stagnation of bacteria in the intestine, it is normal only in 70% and abnormal in about a third of the cases. And that, as I mentioned earlier, is a condition that can be treated with antibiotics for 2 weeks, and then the patient can feel much better. The problem here is that the bacterial infection may return, and does return in about a third of the cases over the course of the next year. So we need to stay vigilant, and we need to be aggressive about managing these individuals. And there are some patients who actually, after the initial course of therapy, they rapidly develop symptoms, and we keep them as much as possible on some kind of an antibiotic combination over a course of time, up to a year. Moving down the path of the gut, just a few things about the colon and rectum, and I wanted to show you some examples. This is an example of a patient who had severe constipation, and you see actually fluid levels, which are these levels that are straight lines here and here and here. And that, when the patient presented to the emergency room, they thought that they had bowel obstruction. And basically, after they tried to do all kinds of tests to figure it out, they found out that there was no bowel obstruction, but there was a pseudo-obstruction based on the abnormal motility of the structures of the gut. This is another example. What you see here, when we look inside the bowel directly, we have this obstacle here. This is a piece of stool, which is as big as an apple. The patient does not feel it, but it blocks the passage of things through to the point that they can be eliminated. So this is examples of patients with Parkinson's disease with acute distension, pain, and severe constipation. This is the bowel. On a CAT scan, it's full of air. It does not go anywhere. Here is another example. When we look inside, we find the spasticity of the bowel, which is very, very tight at this level. And unless we take the scope through to open and drain things from the inside, the patient will not feel any better. This is another example in which the surgeon had to be involved to find out that the portion of the bowel was not working and had developed something that's called a volvulus. And that requires surgery to resect portion of the bowel and then reconnect the two pieces. Briefly, which is not something that I would like to give you details because it's very sophisticated stuff, there are 4 types of defecatory dyssynergia. This is a fancy term that we use to demonstrate or classify what's going on. The main thing that is going on in the Parkinson's population is that they have an effort from the distal portion of the bowel to push and an anal canal that's very, very tight. So this coordination, in other words, the bowel is pushing to evacuate, and at the same time the anal canal is staying strong. It's basically the most common abnormality in patients with Parkinson's disease. And again, this is another example of when we studied 96 patients with Parkinson's disease, we found that they had 89% of them had abnormal manometry, 62% had abnormal wireless motility capsule, and 57% had basically abnormalities in both these tests. In other words, the bowel transit was impaired, the coordination of the distal part of the bowel was not good, and sometimes both systems were not working very well, contributing to significant constipation. And if you look at the severity, the majority of the patients complained of infrequent bowel evacuation and also from straining. In other words, they were struggling to evacuate their bowels. And we'll move on. These are the different types of dyssynergia, which I will not really bore you with. But we have a variety of classifications shown here, in which, as we combine the studies and we try to understand what's happening, there's a variety of possibilities shown here, in which, unless we really use the tools to understand the situation on a particular patient, we will not be able to tell for sure what is going on and what we can do about it. The colon transit times are very, very abnormal, so in the sense that you see here, the normal transit time should be out there. In the patient with Parkinson's disease, it can be quite significant, sometimes double, sometimes threefold increase in the timing that's required to expel the bowel. Something that we have used quite successfully in some patients is endoscopic Botox injection, and this is not cosmetic. This is purely for purposes to help the muscles relax and to help the muscles coordinate. And this Botox injection can be either used for the stomach, in which we relax the sphincter muscle that delivers the goods into the small bowel. It can be used for spasticity of the esophagus, in which, if there's spastic esophagus, we can count down the esophagus so that they can improve the difficulty swallowing. And also in the distal part of the anal canal, where when there is incoordination between the anus and the rectum and the muscles of the colon, then we relax the anal sphincter so there is a better coordination. So depending on the location of the problem, or sometimes the multi-localization of the problem, we can use Botox. The problem with Botox is, first, it is expensive, sometimes not covered by insurance. Medicare does approve it in general. I have to lie to them, but that's okay. Bottom line is that there is a problem with coverage. And the second issue is that it does not work long. I mean, it usually lasts for about 8 months. And sometimes if you use it multiple times, that 8-month period goes down to 6 and so forth. So it's not a permanent effect. But as I said earlier, you can actually assess the symptoms of the esophagus, the stomach or the pylorus, as well as the anal canal. And depending on the symptom combination, you can study the patient and then apply the Botox for the therapeutic gain. And if you look at the response to Botox injection by location, this is the esophagus, this is the pylorus or the stomach, and this is the anal canal. You do have, the best result is with the pylorus or the stomach, but you also get some benefits in the esophagus or the anorectal sphincter area. So, to summarize, and probably I'll be able to take questions, the high-resolution manometer, which is a test that takes 10 minutes, classifies and helps us out in managing the difficulty swallowing. For the gastroparesis in patients with Parkinson's disease, that it does contribute not only to symptoms such as bloating and weight loss, but also to poor drug efficacy because the drugs or the pills stagnate in the stomach. And speaking of this, by the way, there is a way to bypass the stomach and deliver the medication directly into the small bowel. It does require, however, a tube. The lactulose breath test detects small bowel bacterial overgrowth and applies to the patient who have this condition that can be treated with antibiotics, and that way it guides us therapeutically. There's the wireless motility capsule that's a valuable clinical tool since it highlights unsuspected abnormalities amenable to therapy. The majority of patients with Parkinson's disease may have overlapping constipation and will need therapy for both the incoordination at the bottom part as well as the slow, very sluggish bowel evacuation. Fiber is not well tolerated. I made that point very clear because most patients have this inability to move things through the colon, and if you pack it up with fiber that stagnates in the bowel, they feel worse and their bloating gets worse. Since the rectal sensation is frequently preserved, bulking with fiber that aims at improve that sensation is not good. Physical therapy should be tried in patients with this incoordination between the rectum and the bowel and the anal canal, but its efficacy is not known. People may have to go to physical therapy for pelvic floor. That's a different physical therapy that we probably hear about. That requires weekly appointments, manipulation by physical therapy, so it's not particularly useful, although I did not show you the data. And in terms of other therapeutic implications, osmotic laxatives such as linaclotide and lubiprostone could be useful in the treatment of patients with colonic inertia, since they basically shorten the passage of things through the bowel. Since many Parkinson's patients have constipation, have low anal pressures, the occurrence of fecal incontinence may be limited. And so we need to really find out what's the right amount of medicine that makes you constipated or relieves you from the constipation and to prevent the fecal incontinence. There are some other patients, depending on what abnormalities we find, that may need something that we call programmed defecation, in which on a daily basis there is some kind of a digital manipulation of the distal part of the bowel to facilitate evacuation. And this happens irrespective of what the patient's complaining about, because we have defined where they are on the basis of the testing and clinical questionnaires, and then we apply this program, and they do generally very well. And finally, a few words about Botox therapy that can be useful in some patients with Parkinson's disease, depending on what they're suffering from, such as difficulty swallowing, bloating, and constipation due to defecatory dysfunction. And I would like to say thanks to some of my colleagues who helped me do that research, and we'll continue to work together. Part of these individuals have moved to other things, but some other people have actually replaced them. And I would like you to consider, I understand the distance between here and down there where I am is significant, but in case you want to help any research programs that we have, we'll be happy to do that. And I would like to thank you for your attention very much. Thank you. Any questions? Yes?
Why is there no mention of probiotics in any place?
The probiotics are usually used after you have the need, first of all, after you have treated the small bowel bacterial overgrowth, and the goal there is to try to prevent the bad bacteria from accumulating. So we usually do that after the initial therapy with antibiotics to try to contain the problem from recurring afterwards.
What about before that happens?
Before, that's fine too. And if the problem there is that you don't really know if it helps you or not, and you spend a fair amount of money there for no reason. Yes?
How do you feel about the use of stool softeners like Docusate?
That's fine too. It's an early and generally harmless approach.
Even used daily?
Oh yeah, there's no risk there. Ma'am?
Can you talk a little bit about the GERD? Is that just part of the esophageal?
Yeah, the GERD, by the way, means that you have a sensation of burning in the chest or a fluid coming up into the chest. GERD is a very common condition that applies to anybody. In the context of a patient with Parkinson's disease, the difficulty is that GERD could be a manifestation of the slow stomach emptying. Things are backing up, And the other possibility is that you may have spasticity in the esophagus, and that is a little bit confusing because it gives you the same symptoms as GERD does. So again, it would be useful to understand what's going on in a patient with Parkinson's disease, as well as patients with GERD symptoms, because if you have either spasticity of the esophagus or you have ineffective contractility of the esophagus, both of those scenarios can happen in patients with Parkinson's disease, then the manifestations are very similar to patients with GERD, and you cannot tell the difference unless you study them properly. For playing the statistical odds here in a patient with Parkinson's disease, high protein diet, liquid diet is actually good for the stomach situation. For the constipation, taking, let's say, like colase, any of these laxatives that are either mild or the osmotic laxatives, which are a little bit stronger, like Miralax, which is over the counter, is actually quite effective. The downside of that is that you may actually have a situation in which fecal incontinence may happen. So you need to balance all of these. I'm talking about preventive foods because you don't want to really allow the patient to develop weight loss, because that actually is a bad thing. Any diet will be fine. Any balanced diet, Mediterranean diet, whatever, it's fine as long as you don't overdo the fiber.
Repeat the question, please.
Yeah, the daily use of glycerin suppositories, and that can actually be good. It stimulates the rectum to evacuate, and that can be done on a daily basis or even twice daily, as long as the patient is willing to go to the bathroom twice daily. It's the emptying of the rectum is the most important part. Yes?
I just wanted to know the usefulness of taking prunes or prune juice.
Yes, it's fine because it treats the constipation relatively effectively. Don't overdo it because it's fiber. But if it works, that's fine too, as long as there's a bowel movement that happens every day and there's a complete sensation that the patient has emptied their bowels. Yeah, usually it works for me better if a neurologist sends me some general assessment or appreciation of what's going on, because that helps in knowing the background, although I'm so experienced with this that I can actually figure it out from a neurologic perspective, but I don't want to act like smart. I usually want to have an idea of some kind of an objective neurologic assessment that has been done by a movement disorder specialist. It's not necessary for me to have a referral from these people, and people can walk into my office as long as they make an appointment, which is about a couple of months out, but I'll be happy to help.
Would a constant need to clear the throat be an indication of like dysphagia?
Yes, that's another way of what we say dysphagia. The problem is that it's not possible to distinguish if it's oropharyngeal up here versus esophageal, and that's why you may have to have both of those tests or both of those assessments made.
Okay.
But it can be a symptom of esophageal dysfunction or pharyngeal dysfunction, and it's actually quite common in patients with Parkinson's disease.
So is that something that we would ask the neurologist about then and try to get a referral out, or I mean how?
You could do that. Many times the non-specialist neurologists kind of don't pay too much attention because it's such a classic symptom of Parkinson's disease.
Yeah.
But if you want to interfere and do something about all of these things that you heard, probably a referral will be useful.
Okay, thank you.
Sir?
Is there a connection to proper hydration and helping with the bowel movements?
Actually, that's a very common misunderstanding. The thought is that we hydrate ourselves and we think that we're going to move our bowels better. And this is not specific to Parkinson's, to everybody. What happens though is that the fluid that we drink is getting absorbed and it's not going to really get down to the bottom. What the drugs are doing, the osmotic laxatives, is that they suck and keep the water in. But if you just drink water, for example, that water is going to be absorbed. Or normally we make about 5 to 6 liters of fluid every time we move our bowels. It's only about 300 to 500 cc's of that fluid that come out. So the colon basically sucks all this water. So we drink all the water and then the colon goes up and sucks it up and produces the same thing. Sir?
keto diet, how good is that for us?
I have no idea. It's obviously publicized a lot, but I don't have any data to tell me what's going on. And personally, I don't think it's useful in even the normal individuals who have no neurologic disease. Sir,
In your studies, have you encountered individuals with lymph node, throat, and mouth cancer, let's say a loss of 88 lymph nodes, and the relationship between the difficulty swallowing with their reduced throat and the Parkinson's? Have you encountered that conflict?
actually, what happens in the population that you mentioned with the lymph node resection and cancer of the oropharynx, as we call it, is a structural problem, and it reduces the production of saliva. So, as by itself is a cause of difficulty swallowing. To add to that, a patient with Parkinson's disease, because of they have additional neurologic deficits to the neurologic deficits that were basically a result of the surgery that they had, and the lymph node resection and the variety of glands that are reduced and removed, complicates things. To what degree there is a relationship between the two, I don't think that there is, but the two combined can cause a significant derangement, for sure. Yes, sir.
How about magnesium as an osmotic laxative?
Magnesium creates a little bit of a secretion, and it actually could be an effective treatment for patients who have gut problems, particularly constipation in Parkinson's disease. So it's not accumulating or distending the bowel, but it helps the bowel contract.
We've had good luck with that.
I don't have any dispute there. Ma'am?
Yeah, if the impaction in the lower colon is visible and palpable from the outside, is it all right to massage that area, trying to move it through?
Yes, this is what we call the digital maneuver or digital manipulation. What it does, it stimulates the rectum and creates a little bit of a higher tone in that area that sometimes overcomes the anal sphincter, which is not properly relaxing.
But a massage from the outside, not the
Oh, no, from the outside, not really. Although for people who have slow transit from the bowel, if massage the front of the abdomen actually can be useful, but the efficacy is not particularly as good as what I just said, which is you put the finger up and you start manipulating the rectum. So it can be useful in some individuals, especially those who have lost the tone of the bowel, which happens a lot. Sir?
Yeah, there was a study that came out this month about a probiotic that might reduce the amount of alpha-synuclein produced.
I haven't seen the study. I would love to see it and help you out.
If you have mild symptoms of, let's say, dysphagia, is there, could an increase in carbidopa levodopa help? Does that help that?
Well, obviously, it all depends what kind of, that's why I said earlier that unless you study what is the source of the difficulty swallowing, it's very hard to say if it is related to the back of the throat versus the esophagus, and what particular condition you have in the esophagus or the back of the throat. Unless you know that, it's very difficult to lump everything together. So I would suggest that you either talk to the speech therapist or to the gastroenterologist who does these kinds of things to really facilitate that. Because there's a lot of drug effects that, for example, dry the mouth, and that do not facilitate the lubrication, if you will, of the process of the swallowing. So it's a very difficult question, very appropriate question, but very difficult to answer. Yes, ma'am.
So it's been suggested that we eliminate milk products, dairy products?
Nothing to do with anything.
No.
No.
What about...
Irrelevant.
And what do you think about gluten-free?
Oh my God. It will drive your cost of groceries significantly, and I don't really think that there's a reason there. So let's stop there. Yes, and
We're a little bit new to this, so my question is, should you just wait until these kind of symptoms present themselves, or should you talk to your physician and request these tests?
Well-
Because you're saying, I mean, if you're able to determine it even prior to them presenting, then that would be beneficial and it would be prudent.
in our practice, we, as gastroenterologists in general, we tend to intervene if there are any symptoms, because we don't want to make people worse than they are. If the symptoms are not bothering, I personally do not recommend any intervention unless I find something objectively by examination or by a patient who tells me that their quality of life is significantly affected by this particular symptom. Otherwise, you will actually overtreat people from my perspective, as well as they're taking already medications for the neurologic condition. I think it's too much. Already a patient with Parkinson's disease takes a lot of pills, so why should I add another burden to them? So my personal bias is to have a conversation, and based on that conversation, make some decisions of what is worth attending to and what is not.
Thank you.
Sir?
Do vegetables help elimination?
They may, as long as it's not in excess, and they don't really create this bloating sensation. And what I'm seeing a lot is people taking commercially available fiber, which is like vegetables, and that actually traps itself in the bowel because it does not work very well in the patient population with Parkinson's disease. Sir?
I read about years ago of a study where they actually introduced enzymes from healthy individuals into people's guts, and they had significant improvement in anyway, improved their health. I'm wondering, did you explore that? And if so, why not?
We do explore it, although what you need to know is that it's not as simple. The process is much more convoluted. So the enzymes that we're talking about usually are made by our pancreas, and they're delivered into the bowel and they help with the digestion. To what degree they will help with the digestion or the breakdown of particular molecules, such as the pills that one takes, is unclear and is very unlikely to be happening. The most important point, though, is that introducing enzymes by mouth in the form of some kind of an enzyme, they break down into the stomach because of the stomach acidity. And by the time they get into the bowel, they are inactive. So you're paying money for no reason.
It was also introduced rectally.
Rectally?
As well.
Great, even worse. I'm sorry, I may sound a little bit peculiar, but the point is that the colon is not contributing to any kind of absorptive capacity other than water and electrolytes. So basically the purpose of the bowel is to desiccate the stool and make it a little harder so it does not get out in the form of diarrhea or in the form of lack of control. So that's the only function of the bowel. There is some absorptive ability of the bowel, but this is for molecules that are pharmacologic, not enzymes. The enzymes have to be delivered locally and work enzymatically directly where the food is, and there's not very much food in the colon. It's just all useless stuff. Yes, ma'am.
I was just wondering if you got any insights through your studies about the fecal incontinence or suggestions about that.
Yeah, depending on the findings of the test that we're doing, we can actually do either physical therapy or endoscopic interventional approaches to tighten up the muscle that controls the continence, or sometimes with drugs such as Imodium, which works in many patients, probably the majority of patients. But that's, again, you're taking a risk of constipation induction versus treatment of the incontinence. And sometimes, to make things a little bit worse, is that one of the reasons for the incontinence is that the patient has accumulated so much stool in the colon, has stretched it out, and then there is flow around the stool that blocks the bowel, that comes out as a flow or as incontinence. So that is relatively easy to understand and to make the diagnosis by introducing the finger. I'm introducing the finger into the rectum. If I find that the patient has something that we call impaction, and the fecal incontinence happens around that impaction, then we have to treat the constipation first, and then most likely that will eliminate the incontinence. So it's kind of a little bit convoluted, but it's relatively easy to address. Man.
I said, what, question, you know, a lot of time, timing of taking carbidopa-levodopa, you know, you're supposed to do it, you know, on an empty stomach and then wait a while. Do you think that really matters?
It does matter in the sense that you prefer to have the direct delivery to the bowel at the time that you use a carbidopa-levodopa, but it also may create a bit more constipation. So it's a tough situation. But in terms of the delivery of the drug, delivering it into the stomach and then in turn into the bowel where it gets absorbed may make a difference. You don't want it to have mixing, if you will, of things together. Sir?
You don't want the inhaler system of L-dopa?
That would be great. I don't really know specifically the studies behind this, but it may have some advantages.
Yeah, basically, it basically involves a capsule, the capsules, and I have them here, it works pretty well.
Yeah. I
You gotta know, you know, it bypasses the entire, it goes direct to the lung.
Yeah, if it gets absorbed, actually.
Yeah, it works fast, too.
It works fast, too. Like cocaine. Stop? Okay, I'm stopped. Thank you all.